So this is the second section of our lecture. In this section, we are going to discuss syndrome of inappropriate antidiuretic hormone. This syndrome is characterized by the excessive, unsuppressible release of antidiuretic hormone that is coming either from the posterior pituitary or from an abnormal non-pituitary source. Due to this unsuppressible release of ADH, there will be increased solute-free water reabsorption by the renal tubules into the venous circulation. Let's discuss this syndrome in detail. So this section will cover the clinical features of SIADH, its etiology, and the pathophysiology of SIADH. Now, what is hyponatremia due to inappropriate antidiuresis? Decrease in plasma osmolarity or sodium below the normal range, that is hypotonic hyponatremia, hypervolemic hyponatremia, and hypovolemic hyponatremia, and there is euvolemic hyponatremia. So these are the three main types by which in which the patient can present, and these are the three main causes by which there is hyponatremia can be caused in the body. The first one is hypervolemic hyponatremia, in which there is increase in total body water that exceeds the increase in total body sodium. So the water content of the body is increased as compared to more as compared to the sodium content of the body. In hypovolemic hyponatremia, there is decrease in body sodium more than the decrease in body water. So what is happening here? Both of the components are decreasing, but sodium has decreased more as compared to water. And in the third form, that is euvolemic hyponatremia, there is increase in body water with little or no change in body sodium. So the body water is increasing, but the sodium is not changing. It is in the normal condition, normal levels. So all the three forms are associated with failure. What happens is they are unable to fully dilute the urine, and they mount a water diuresis in the face of hypotonic hyponatremia. Hypervolemic hyponatremia, the causes are there is severe congestive heart failure or cirrhosis. In case of hypovolemic hyponatremia, it can be caused by severe diarrhea, diuretic abuse, or mineralocorticoid deficiency. Whereas in case of euvolemic hyponatremia, it can be caused by expansion of total body water by excessive intake in the face of defect in urinary dilution. Now, the impaired dilution is caused by either there is a defect in osmotic suppression of AVP. And what are the causes of defect in osmotic suppression of AVP? They can be certain non-hemodynamic stimuli like nausea or cortisol deficiency, and it can be corrected by treatment with antiemetics or cortisol. Or there can be a primary defect in osmoregulation. This primary defect in osmoregulation, it can be caused by certain disorders like malignancy, stroke, or syndrome of inappropriate antidiuretic hormone, and it cannot be easily or quickly corrected. So these are the two main causes through which there is osmotic suppression of AVP, which can be due to non-hemodynamic stimuli, and it can be due to primary defects in osmoregulation. Euvolemic hyponatremia results from AVP-independent activation of the renal V2 receptors, and this variant of euvolemic hyponatremia is called nephrogenic inappropriate antidiuresis or NSIAD, in which there is no AVP, but still the renal V2 receptors are activated. Now, the clinical characteristics constitute of decreased volume and increased urine concentration. If it is not accompanied by a commensurate reduction in fluid intake or increase in insensible losses, Reduction in urine output will result in excessive water retention. And due to this excessive water retention, the patient will experience hyponatremia. This excessive water retention will expand and dilute all the body fluids. If the patient is asymptomatic, if the hyponatremia develops gradually, the patient will experience minor symptoms or no symptoms at all, and they will be asymptomatic. If the patient is symptomatic, it means that the hyponatremia has developed acutely. And in case of severe acute hyponatremia, the condition of the patient will be extremely deteriorating, or this can be lethal for the patient. The patient might experience signs and symptoms of water intoxication. They will have a mild headache, confusion, anorexia, nausea, vomiting, and if it is severely acute, the patient might experience coma. And lastly, convulsions. Hypervolemic form, if we specifically talk about the forms, they are related with certain specific symptoms. The hypervolemic form, in which there is increase in the total body water, the patient will present with generalized edema, or there will be signs of marked volume expansion. In case of the hypovolemic form, the patient will present with the signs and symptoms of dehydration, such as tachycardia, loss of skin turgor, and etc. And there will be signs of marked volume depletion. Signs of volume expansion or contraction. These are absent in case of SIADH, SIAD, and other forms of euvolemic hyponatremia. Moving on to the etiology of SIADH, it can be caused because of certain neoplasms. These neoplasms are responsible for the ectopic production of AVP through the abnormal expression of AVP-NP2 gene. These include carcinomas like carcinomas of lung, duodenum, or pancreas, certain bladder, ureter, or ovarian carcinomas, and other neoplasms including thymoma, mesothelioma, bronchial adenoma, and carcinoid or gangliocytoma. The patient SIADH can be caused by head trauma. It can be caused by certain infections which are responsible for the eutopic release of AVP. Those infections include pneumonia and TB, bacterial or viral abscesses, lung or brain cavitations, and lung or brain meningitis. It can be caused by certain vascular causes, such as cerebrovascular occlusions, hemorrhage. Moving on to the causes of SIADH, there are certain other causes, such as neurologic, in which there is also eutopic release of AVP. It can be due to multiple sclerosis, peripheral neuropathies, certain delirium tremens, and ALS or hydrocaph. These are all the neurologic causes. The congenital causes include agenesis of corpus callosum, cleft lip, palate, and certain other midline defects. The metabolic causes include acute intermittent porphyria, pulmonary asthma and pneumothorax, and the drugs. There are certain drugs which can also cause syndrome of inappropriate antidiuretic hormone. These include SSRIs and carbamazepine. Nicotine and phenothiazines are also the culprits, and cyclophosphamide and TCIs, tricyclic antidepressant, they can also cause SIADH. And it can also be caused by the exogenous administration of SIADH in the form of vasopressin or desmopressin or oxytocin high dose. In SIADH, there is inappropriate secretion of AVP. It has many different causes, ectopic production of AVP by the lung cancer or other neoplasms, and eutopic release induced by various diseases or drugs. And there is exogenous administration of AVP, DDAVP, or large doses of oxytocin. The ectopic forms occur in patients with acute infections or strokes. They result from abnormal expression of the AVP-NP2 gene either by primary or metastatic malignancies. The patterns of ADH secretion. Whenever there is defect in osmoregulation, it can take any of the four distinct forms. Number one, it can be erratic, unregulated release of ADH, which is not related to plasma osmolarity. Number two, it can be modest and constant leak of ADH. Number three, which is the most common type, there is downward resetting of the osmostat, which leads to increased ADH secretion because the stimulus or the threshold can be reached more easily. And the plasma sodium concentration normally regulated or stable at lower level, that is 125 to 135 milliequivalents per liter in this type. Now, the AVP secretion that is fully responsive to changes in plasma osmolarity and sodium. Because of the osmoregulatory threshold is low, patients differ from those with other types of SIADH. They are able to maximally suppress the plasma AVP and dilute their urine. And if the fluid intake is high enough to reduce their plasma osmolarity or sodium to the new set point. In most patients, SIADH is self-limited. It remits spontaneously within 2 to 3 weeks, and 10% of the cases are chronic. Patterns of ADH secretion. We said there are 4 patterns. So now this is the 4th pattern in which is most common in young boys, around 10% of the cases. It occurs due to a germ cell mutation in the V2 receptor, which leads to the activation of this receptor. Due to the activation of V2 receptor, there will be inappropriate antidiuresis without the defect in osmoregulation of plasma AVP. Normal ADH secretion, but the urine will still be concentrated. And the production of antidiuretic compound NSAID and antidiuresis in this case appears to be permanent. So type D, in type D there is no excessive production of ADH, but the urine is still concentrated because there is a germ cell mutation in the V2 receptors which leads to its activation. Talking about the pathophysiology of SIADH, increased ADH levels lead to act on the renal tubules and make them permeable to water. This increased permeability leads to water reabsorption. Whenever there is increased water reabsorption, the urine volume will decrease. It will increase the urine osmolality and it will increase the urinary sodium. Increase blood volume, increased serum hypoosmolality. Both of these will cause dilutional hyponatremia because the blood volume is increasing, kidneys are retaining water in the body, sodium is not changing, so the water content, due to the increase in water content, it will lead to dilutional hyponatremia. This dilutional hyponatremia will cause the signs and symptoms of water intoxication that include anorexia, nausea, vomiting, or it can be irritability, confusion, hallucinations, and seizures if there is excessive retention of water. Impaired osmotic suppression of antidiuresis will lead to excessive retention of water and a dilution of body fluids. If water intake exceeds the insensible and urinary losses, there will be defect in osmoregulation of thirst, dipsogenic. It can be psychogenic or iatrogenic, including excessive IV administration of the hypotonic fluids. In SIADH and other forms of euvolemic hyponatremia, there is decrease in plasma osmolarity and sodium, which leads to increase in extracellular and intracellular volume. This increase in extracellular and intracellular volume, it is proportional to the amount of water that is retained. Now, increase in body water of 10%, that is 4 liters in a 70 kg adult, it reduces the plasma osmolarity and sodium by almost 10%, which is equal. And that reduction in plasma osmolarity is almost around 28 milliosmoles per liter or 14 milliequivalents per liter. Increase in body water of this magnitude, it is rarely detected on physical examination, but it can be reflected by measuring the weight of the patient with a weight gain of almost 4 kg. It increases the GFR and ANP, atrial natriuretic hormone. This ANP and increased GFR will suppress the plasma renin activity, increasing urinary sodium excretion. So this is a compensatory mechanism that the body is trying to balance. This is not a compensatory mechanism. Basically, the body is excreting sodium, so it will result in the severity of dilutional hyponatremia. This resultant reduction in total body sodium will decrease the expansion of extracellular volume, which leads to the increases in brain swelling and increased intracranial pressure. Due to this increased intracranial pressure and brain swelling, there will be symptoms of acute water intoxication. The swelling will be counteracted by inactivation or elimination of intracellular solutes. These intracellular elimination of this intracellular solutes will cause a remission of symptoms even hyponatremia persists. It will aggravate the hyponatremia and expand intracellular volume further, making the condition even worse. In type 1 or type 2 hyponatremia, osmotic suppression of AVP secretion that is counteracted by hemodynamic stimulus. There will be a large reduction in the cardiac output, reduction in effective blood volume, and antidiuresis that is enhanced by decreased distal delivery of the glomerular filter rate. All this results from increased reabsorption of sodium in proximal nephron. Reduction in urine output is not associated with reduction in water intake or an increase in insensible losses. The patient will keep drinking more water, they will feel thirsty, and which will make the condition even worse. The body fluids will expand further and they will be diluted. They will cause hyponatremia despite increase in body sodium. Glomerular filter rate will be reduced further. Plasma renin activity and aldosterone will be increased. And unlike SIADH and other forms of euvolemic hyponatremia, it is going to cause hyponatremia despite increase in body sodium. The rate of urinary sodium excretion will be low. In that case, hyponatremia is usually accompanied by edema and hypokalemia or azotemia and hyperuricemia. In type 2, hyponatremia, sodium and water retained as appropriate response to severe depletion. So this was all about the pathophysiology of SIADH. Keep watching other sections of this lecture.